you for joining us today. I'm Holly. I'm a nurse by background and I work for Aqua as the immunisation educator. So today is just a brief overview on HPV and mainly covering the change in the vaccine schedule. As you might be aware, is now one dose only for full coverage. So we'll sort of blitz through that. There's some time for questions at the end if you do have any, but because there's so few of us today, feel free to interrupt if you've got questions in between. So human papillomavirus. Well, first of all, I'd like to acknowledge the lands which I'm talking from today, the Whadjuk tribe of the Noongar Nation. Pay my respect to elders past, present and emerging, and also acknowledge the Aboriginal people in the room today and on the call. So what is HPV? So as the title sort of says, it's a virus and it's an STI, so it's spread through sexual contact. It affects mainly the skin and the mucous membranes. There's loads of different types of them, so over 200 so far that they've found. And an interesting fact, the papilloma part is actually a term for wart, which is sometimes a symptom of some of the HPV infections. So a little bit about epidemiology. So the main thing, definitely when you're communicating with patients, is to let them know it's a very common virus. So up to 90% of sexually active people will be infected with at least one type of HPV during their lifetime. The transmission, so we've said it's through sex. It's not actually through body fluids, so semen or saliva, or vaginal secretions. It's actually skin-to-skin contact is how it's spread. So it relies on little microabrasions in usually genital areas, and that's how the virus is spread. It's very transmissible, so unfortunately it does spread very easily. So about 50 to 80% chance of you contracting HPV if you are having unprotected sexual intercourse with someone who's positive. Reservoir, so it's only humans, as again the title indicates, human papillomavirus. And the people who are most at risk and most affected by HPV and associated diseases are men who have sex with men and people who are immunocompromised. So the main thing with HPV is the link to cancer, and we'll get on to cervical cancer, which is probably the most common one that people associate it with. But it's important to recognise that there are lots of other cancers which are linked to HPV and are becoming more prevalent nowadays. It's not all bad news. So most of the time with HPV infections, the body's immune system actually clears it, and you don't know you're infected, and within 2 years the infection's resolved. But there are a small proportion of those HPV infections that can progress and lead to cancer. So the biggest one is cervical cancer. So 95% of cervical cancer is due to HPV. And of those 200 subtypes, 16 and 18 are about 70% of the cervical cancer. So it's a huge amount. Which is why back in 2020, WHO outlined a strategy to actually eliminate cervical cancer. And that's the first time that anyone's been able to sort of envision a plan of completely eradicating a cancer. So it's a very exciting thing that we can do. And the main thing is vaccination, screening, so cervical screening, and improving treatment for people who do have cervical cancer. And another good news story is that in Australia, we're doing very well. Broadly speaking, vaccination rates are improving, screening coverage is improving, and we're on track to hopefully sort of reduce it as a public health issue by 2035. So we're sort of on target for that. So just to briefly touch on the types of HPV, so I sort of said at the beginning, it affects the skin and the mucosa. So the skin, cutaneous, another word for that. You've probably seen sort of hand warts, foot warts, so just your sort of common warts, that's actually caused by HPV. So all warts are caused by HPV. No cancerous ones come from the ones that affect the skin. So it's mainly the mucosal sorry, I'm just gonna, can I scooch that? Yeah. It's mainly the mucosal ones, which can unfortunately turn into cancer. So you're thinking about the vagina, cervix, vulva, anus, foreskin, and even the urethra. You're also thinking about the nose, the mouth, and the throat as well. So you can get head and neck cancers from HPV. And this is just a slide looking at the mucosal HPV. So you've got about 40 types within that subsector. You've got the high risk ones, the 16 and 18, as we covered, around cervical cancer. There are obviously others that are linked to cervical cancer. Lower risk ones are here. So 6 and 11 are the most common for genital warts. So it's just something to be noted. And then there are some that we're continuing to study at the moment. We don't know sort of what their links are, but they're not thought to be significant. So symptoms, how do you know if you've got HPV? Well, most people don't. Most people don't know they've got the virus because there are no symptoms or signs of infection. You don't tend to feel unwell with it. There are obviously the exception, things like genital warts and the hand warts that we spoke about, which is a presentation of HPV. But the other good news is that we've got a really good vaccine at the moment. We've been using since about 2008 in Australia. So it's the 9-valent HPV vaccine. And the 9-valent refers to the 9 different strains that's covered in the vaccine. And sort of risk of repeating myself, you've got the 6 and the 11 for the genital warts coverage, the 16 and the 18 for the cervical cancer coverage, and the other sort of cancer-linked strains. It's not a live vaccine, so it does mean that a lot of people can have it, and its side effects are mild in comparison with live vaccines. So it's a really good one on the market, and the only one that we use in Australia. So roughly how it works, without boring you with going into the immune system too much, but the HPV vaccine contains virus-like particles, so it's not the actual virus itself, it's mimicking it. They're not infectious, you can't get HPV from the vaccine, so they don't actually have the DNA of the virus. But it tricks the body, so it looks so much like the virus that would create good antibodies against HPV. And the VLPs, the virus-like particles, are really, really effective and create a really good immune response as well. So it's been proven to be, a highly effective vaccine. The other thing to communicate, sometimes patients will get confused about the vaccine being a treatment for HPV. So it's important to communicate with them that it's preventing HPV infection, but not actually treating the disease. And just a brief slide about the effectiveness of it. So the 2 main headlines really is that a single dose, of which we've now changed to in Australia, is highly effective. So over 90% of persistent HPV infections will be prevented by that. And it's those persistent types that cause cancer. So that's the important part. And it also provides long-term immunogenicity, which basically just means that you remain immune for long. So a good number of years afterwards has now been shown to be effective for. Who is eligible? So anyone, boy, girl, from 12 to 13 should be getting it routinely now. And it's usually given at school. The most common time that people actually get HPV is when they first start having sexual intercourse. So really you're trying to capture that group before that's happened. And now there's a catch-up schedule for everyone from 14 to 25. If they haven't had the vaccine in the past, they're eligible to have it for free on the National Immunisation Programme. People who are immunocompromised do need doses as well, despite whatever age they are. They need 3 doses actually of the HPV vaccine, so that's slightly different. And men who have sex with men are a little bit more complex, so they are definitely an at-risk group, and in the immunisation handbook it's recommended that men who have sex with men of any age should have the HPV vaccine, but it's not actually funded on the National Immunisation Programme over the age of 26. So if you turn up to your GP and you're that sort of cohort of patient over 26, then it would be a private prescription. But if you're based in Perth, and lots of sexual health clinics actually do offer it for free. So that's a good alternative for those patients. And the main headline is the change to the single dose. So originally was 2 dose, but in February this year, it was decided that single dose is just as effective. And that's using a lot of different studies from nationally and internationally. It's also going to be adopted in the UK as well soon. However, just to note, the immunocompromised adults, the immunocompromised people and adults over 26 should still receive the 3 doses, but that's all in the immunisation handbook. And that's just a good table summarising the changes that have happened from 2022 to 2023, funding differences. And that's just another little table looking at the different doses that each cohort needs. So 9 to 25, a single dose is fine. Over 26, you need 3, and immunocompromised, you need 3 doses. And just a brief overview, it's given as an IM, intramuscular injection, usually into the deltoid. And that's just a little diagram showing you the classic sort of upside down triangle over the deltoid, and you're sort of aiming for the middle of that. Adverse effects. So as I sort of touched on, it's not a live vaccine, so you don't tend to get sort of the big systemic effects of fevers and things like that. But the main thing is site reactions. So like with the flu vaccine, really, you get a sore, achy, red arm for a few days. That is very common. There are other effects that have been reported that are less common, so headache, fever, nausea, dizziness, fatigue. But it's got a really good safety profile, and it's generally safe for a lot of people, but we'll go on to the subsets. So the people who can't have it, pretty obvious, I imagine, but anaphylaxis, so an allergic reaction to a previous dose of HPV vaccine or any component in that vaccine, and yeast as well. That's only with the 9-valent vaccine. Precautions. So the vaccine isn't recommended for pregnant women purely because there's not enough evidence to show that it's safe to give to pregnant women. So there's nothing to say it's not, but there's not enough to say it is. But breastfeeding women can have the HPV vaccine. And the same with any sort of medical treatment or vaccine, you need to have informed consent as a clinician giving that vaccine. So it means that they've got to have the legal capacity to consent. So usually that refers to age and mental capacity. It needs to be voluntary, so you're not coercing anyone to have the vaccine. It's got to be specific to the vaccine itself. And the most important things, in my mind anyway, is giving enough time to the patient to answer their questions, give them information in a way that they understand, know the benefits and the risks, and yeah, that's sort of the key. But we're teaching you to suck eggs there. And under 18 years old, obviously that is a large cohort of who you might be offering the HPV vaccine for. So generally parental consent is the way to go. There are cases where you might have a mature minor, so they're under 18, but they usually the GP deems them competent and having capacity to consent, in which there are ways that they can sort of consent to treatment without having the parental consent in place. But that's usually done by a senior clinician. And what about cervical screening? So whilst the HPV vaccine is fantastic, we know that it doesn't cover all strains of HPV. So you've got 9. And all vaccines don't work the same as well in everyone. So it's really important that you continue to advocate for cervical screening and the importance of it. So even when you are giving that to women who've had the HPV vaccine. And just a reminder, it's for women and people with a cervix every 5 years between 25 to 74. And a really positive thing that's happened with that programme as well is that there's now self-collection for cervical screening. So it does mean the eligible sort of cohort of women or people with a cervix can actually do a self-collected vaginal swab rather than actually having to have a full-on sort of speculum exam, which makes it a lot more pleasant experience. So hopefully uptake will keep on improving with that. And it's shown to be just as effective at detecting HPV as those sort of speculum exams done by a GP or a nurse. So I whizzed through that, but is there any questions out there? I don't know actually who's on the call.
I had one question.
Yeah.
With the school immunisation program.
Yeah.
So when they go to schools and give out the vaccination, is that purely just for the 12 to 13-year-olds? Would there be, like, if there's any older, like 14 and up, who in school that didn't get it in that age range, for them to get the catch up, do they only need to go to like external clinics?
That's a really good question. It probably is quite individual, I imagine, with different areas and schools as in themselves. You'd like to hope if you've got a team of nurses going in to do the 12 to 13s that they might be able to capture some of the catch-up sort of schedule. But knowing sometimes how these things are run, it might be quite rigid that they just be giving it to that cohort. So it might be more of a GP route to go down. So them being aware that they're eligible to get it for free from the GP. But yeah, I wouldn't be able to give you a definite answer. I think from the school. Do you know much about
it is, like you said, it is individual, and it depends on the capacity of the either the WA Country Health Service or the Metropolitan Health Service, or whether or not they have the capacity to do that, or whether there's the advice for those people who missed it to actually go to their either Aboriginal Community Controlled Health Service or GP for catch up. But I have spoken to nurses that do catch up when they can. Yeah. So I think it really, I don't think it's, I think it is individual.
Yeah, I guess how much vaccine they're actually
I don't know if there's anybody online who has any feedback about that.
Would it be the children cars, the other service? Do they?
Yes. So they deliver the school vaccinations. Okay. Yes. Yep. In the metropolitan area.
Yeah.
Yeah. And then in the regional areas, you've either got the ones who go into the schools come from Population Health and WA Country Health Services. So, yeah. I mean, the smaller the community, the easier it is to just, young people up to capture them. Yeah. But it's so good now. It's just the one vaccination because, if you're chasing kids up, it's just the one dose, which makes it a lot easier.
Yeah, absolutely. Yeah. And it means a lot of people who were deemed not covered are now covered. Yeah. So, it's really exciting. And a good cost-saving thing as well if you think about going from, halving the amount that you're spending on the vaccine to just one dose. So, yeah.
So is it kids over 15 and over that require 3 doses?
No, over 20, so 26 and over, you need 3 doses, or immunocompromised, you need 3 doses.
Yeah, I just was looking at there was a slide there,
maybe I
just might need to just double
check. You can go
that
back and see.
Yeah, just have a look.
Was it a table?
On? See page 15 years.
Yes, so this is the
2 and above.
2.
Okay, so now 23.
So it's moved. Yeah, it was just showing the. Sorry, it's something that's covering.
Oh, okay, got you.
23.
So now the new one is 26 years and older. They would need 3 doses.
That's the 3 doses.
No, that's so good.
Yeah, it's a huge amount of people.
Yeah, okay, good. Thanks for clarifying that. I was a bit late.
That's fine.
All right. Thanks for coming along.
Yeah,
All
thank
good.
you.
Thanks, Ian.
See you
Nice
for
to
making
see
time.
you.
Yeah,
Okay.
likewise. Bye.
Bye.